Welcome, friends, to Faith in Healthcare. You know, I have an important question I want to ask you. What does every Christian physician, dentist, physician associate, nurse practitioner, healthcare executive, PT, OT, optometrist, basically every member of the healthcare team and all of their trainees have in common? Well, each one needs to know that they are not alone in the exam room, that their faith and their healthcare practice, they're meant to be intimately connected. And that's exactly what CMDA exists to do. Each year through CMDA campus and community ministries, we walk alongside more than 14,000 healthcare trainees and professionals, equipping them to bring the hope and healing of Jesus Christ to every patient they serve. This work simply wouldn't be possible without our dedicated volunteers and the generosity of faithful donors like you. Last month, I shared an exciting opportunity, a $250,000 matching challenge. And today, I'm incredibly grateful to tell you that together we met that full match. Thank you and praise God. But we're not finished yet. As we approach the close of our fiscal year on June 30th, we still have a gap to close to reach our $1.1 million goal. And these final days, friends, are critical. So today, I want to personally invite you. If you've been considering a special year-end gift to support your CMDA, now is that moment. When you give, you're not just giving to another ministry, you're standing with your Christian medical and dental associations as we seek to equip and encourage healthcare professionals on the front lines of faith and medicine. To make your gift, just visit cmda.org/give, or you can call our stewardship team at 888-230-2637. I want to thank you for being a vital part of this mission and for helping your CMDA finish the year strong. Well, now on to this week's episode. There are few drug classes that have generated as much conversation in medicine as quickly as GLP-1 receptor agonists. And it's a conversation happening in primary care offices all across the country every single day. This is the first of two episodes that explore GLP-1s from very different angles. In this episode, Dr. Amy Givler joins us with the clinical perspective. She's a family physician who has served patients in Northeast Louisiana for decades. Dr. Givler is going to bring us both clinical depth and candor to a topic that is transforming how we think about treating diabetes, obesity, and beyond. We're going to talk about how these medications work, who they're for, what the side effects look like, what happens when patients stop taking them, and the honest questions we still can't fully answer. And then next week, we're going to look at GLP-1s from more of a theological, anthropological, and ethical lens. But first, let's dive in on the clinical side. Well, today on Faith in Healthcare, I have a guest whom I have known for many years, and she and her husband, both physicians, and my wife and I have spent a fair amount of time together, whether being on vacation at her place in Rhode Island or traveling across Europe on a Reformation tour last year. Dr. Amy Givler and her husband Don, both physicians. Amy's a family physician who sees outpatients in Monroe, Louisiana, and she and her husband Don, one of their favorite things to do is to go with medical students from their local medical school to Kenya, from LSU Shreveport for a global health rotation. So she's been there to Tenwek Hospital, where I served for a while. She's the mother of three, including one of those is a family physician, so she's surrounded by doctors, and grandmother of four. She's been on our board, I think now 6 years, Amy, is that right?
I think so, yep. Maybe a little more, maybe 7.
And she loves to, this is not her first rodeo. She loves to appear on various podcasts, including one of my favorite, The World and Everything in It, and has been there a number of times. Maybe even, Dr. Givler, talking about the topic that we're going to discuss today, but topics like chronic pain, vaccines, the doctor-patient relationship, and healthy eating, which relates to what we're going to talk about today. So, Dr. Givler, thanks for agreeing to come back, because you've been on the program a couple of times, once as my co-host. Thank you.
Yes, that's right. Last summer. Yeah, thank you so much for having me, Mike.
Well, Amy, just a couple of background comments. Before we jump into a topic, we've been discussing GLP-1s, glucagon-like peptides, for a number of months. And just a few weeks ago, I was the guest with my wife in the home of two family physicians, whom I won't name, but whom you know, who are very busy docs. And I had the chance, knowing that this conversation was coming, to ask them, how much of a role do you play in the lives for your patients, very busy doctors, in terms of prescribing and managing GLP-1s? And they both said about a third of our patients.
Wow.
A third of our patients. And I would say they probably have a normal distribution of the kinds of patients, ages, diseases, and so forth. So I was a little bit blown away by that, Amy, a third of patients. And I also have a very bright chemical engineering nephew who's in Indiana, who took me by the plant that he's helping Eli Lilly build, a $5 billion facility to make Mounjaro, and someday an oral tablet. So I was pretty impressed by that. But on top of all that, in my own family and working environment, I've now counted up to 9 people who are someplace in their journey on being treated and helped by GLP-1. So this is a drug class that's really present. And so when did you first start using these agents, Dr. Givler, and for what purpose?
Yeah. So for most of my career, actually pretty much my whole career, I've been working with indigent patients in Northeast Louisiana, in Monroe. And so my patients don't have a whole lot of money, so they have to get their medications covered by Medicaid or Medicare, or the vast majority of my patients, and a little bit of private insurance, and very little self-pay. So my patients my diabetic patients with diabetes, type 2, I've been using GLP-1s with them, not nearly as effective as the ones we're talking about, the semaglutide and the tirzepatide, but for 10, 15 years, they've been on the market and very effective for diabetic care. They are injections, so they're patients who don't want to take injections, and they haven't been taking them, but they're very effective. And then when these two came out, the semaglutide and then tirzepatide, which is Ozempic and Mounjaro, I jumped pretty much right on board with treating diabetes with these medicines, because I already was comfortable with the class of drug, and in that they were very safe, and the side effects can be tolerated, with tweaking.
Yes.
And I think that that's not usual for me. So usually I am not a jump on the bandwagon, even, glitzy new drugs. I am a wait, a year, 2 years, wait till my patients are really asking about it, which is a year or 2 years, because they don't watch, a lot of advertisements for medications or whatever. But I jumped right on because they were so clearly helping people not only lose weight, but it was really controlling diabetes. So I've been using them now for years, and the public payers, Medicaid and Medicare, are covering them if people have diabetes, but not for the purpose of even pre-diabetes or obesity. So
are there signs that is going to change, just because even though diabetics, obviously the long haul prevention of complications is obvious, but even for others,
Right.
is that going to change?
Yeah, it is. That has already, apparently, there's going to be something they call a bridge program for Medicare patients that's going to start this summer. And it is to provide these medications. If you have to have some, like pre-diabetes, perhaps morbid obesity, I'm not quite sure about that, but cardiovascular indications or whatever. So that is going to get covered by for Medicare patients. So, and we'll see, Medicaid is a tough environment, though.
Well, Dr. Giver, we're going to have some listeners today who are not familiar at all with these medications or how they work. And
Mhm.
I know you've prepared for us maybe a diagram that
Yeah.
we'll put up on the screen at some point. But can you just explain basically how they work?
Yes. So yeah, GLP-1 is a peptide. It's actually a hormone that our bodies make. But our natural GLP-1 exists very briefly in the body because it's metabolized very rapidly. So you think, well, anytime you have a hormone, it has to have a receptor where it's utilized, so somewhere distant. So these GLP-1 is made in the distant small intestine and it travels to wherever there are GLP-1 receptors. And you would think, and this is all the place they looked in the beginning, you'd think, oh, they're in the stomach, because when I tell you how they work, they're in the stomach, they're in the pancreas, parts of the GI system. But you find GLP-1 receptors all over the body. And most importantly, is in the brain, in the hypothalamus. And those GLP-1s activate. So when natural GLP-1s have been mimicked by these medications. So these medications, GLP-1 agonists, are other molecules that act on, receptors that are somewhere in the body. So the receptors that are in the brain have to do with satiety, like feeling full.
Yes.
And it's all about hormones, so that is what we're talking about. We're talking about a hormonal system for regulating how much we eat that God brilliantly did in our bodies. The ones in the stomach delay emptying of the stomach, a delayed gastric emptying. That's where the GLP-1s work in the stomach. And the ones in the pancreas, there's there's different cells. So there's alpha cells and beta cells. And the alpha cells put out glucagon, and glucagon tells the liver to put out more glucose. And so these tampen that down. So there's less glucagon that gets released. And the beta cells, as most people listening will know, are what produce insulin. And insulin is the only cell, it's also a hormone. Well, glucagon is a hormone too. All these are hormones. And the insulin is the only cell that we have that it piggybacks glucose molecules and takes it out of the bloodstream and puts it into the tissue the muscle, the organs, the tissue that needs, that's starving, that's saying, here, give me glucose, give me energy. And so the only cell for that is insulin. That's why we die if we don't have insulin. So that the GLP-1s ask those cells to make more insulin.
So talk about the side effect profile. As the general surgeon in me is thinking about gastric receptors and about slowing motility, that there's got to be, maybe for those already having gastric reflux, that must increase. And
not really reflux as much. I mean, it can, but I recommend, so these are once a week shots. We're basically, I know there's pills out there, and maybe we'll touch on that briefly, but basically we're talking about the shots. And the shots, I recommend to my patients to take it on an empty stomach. So there's not much in the stomach that is now going to be sluggishly emptying, right? And to not eat a gigantic meal right after taking the shot. So, and that decreases the incidence of nausea and vomiting. And so side effects tend to stick with the GI tract, right? So a lot of people have constipation. Ironically, a lot of other people have diarrhea.
And I've heard that from both of those extremes, right, from the people that I know.
Right. So, and then just feeling bloated, but again, that can be mitigated by not having a lot in your stomach. And so because it decreases, because taking it, your appetite is suppressed, because your body's sort of thinks that you've already eaten, So then when you eat, especially if it's somebody who, like obese people, a lot of time talk about just food noise. I don't know if you've ever heard that expression, but just that, oh, I'm always thinking about food. I wish, gosh, I'm hungry right now, and fighting it minute by minute all day long. And that is a lot of people. And so it dampens that down. And people who have started taking these medicines, if that has been the primary reason for their eating more calories than they need, they're like, freedom, finally. I don't feel like I have to eat. I can do other things without putting so much of my brain and energy on telling myself, no, don't get up and go to the refrigerator. So they've been a real boon.
So when patients come to your office, let's talk a little bit about the non-diabetic, because there's no question that the explosion in the last few years has been for obesity. And a JAMA article that I was reading from just about 2 years ago stated, even at that time, maybe on the basis of BMI, but that over 40% of Americans would qualify clinically to take a GLP-1 on the basis of just BMI alone.
Right.
So how many patients now would you say, I talked about others who had a third, but what percentage of your patients with diabetes or not are you treating, and how many are coming to your office and saying, Dr. Givler, I want to try this? And it's one of the things that I thought probably you as primary care doctors, much more than those of us who had patients who were referred to us, me as a surgeon, that probably this comes up more commonly in your practice than it would for mine, that, hey, I saw this on TV, and what do you think about this for my problem?
Right. Yeah, so many people, obesity is exploding in our world, although it's starting to level out, because, at least in America, because of these medications, actually. Because I've taken care of people for, I've been a doctor for a long, long, long time, since '89. And we've never had a medication that helps with obesity that is safe. I mean, I've been very
a lot of fads,
reluctant.
many fads, but they've come and gone.
Many fads, but medications that actually turn out to be dangerous. And I've seen it come and go, and pretty much hasn't been my patients because, again, I'm kind of reluctant
a follower
to jump on bandwagons,
yeah.
Right? Yeah. So but when you talk about adding a medication for obesity, you have to think, well, let's talk about, not only the side effects of the medication, but let's talk about the side effects of obesity. Because obesity is a dangerous condition. Mm-hmm. And it way increases your risk of many cancers and cardiovascular disease and kidney disease. And so earlier Alzheimer's, these are just statistical of, people who are obese are at higher risk for these things. So by treating obesity, so now we're talking about non-diabetics at this moment, but thinking about the obese portion of those people, right? And you think, well, what are the consequences of staying obese or in our current food environment increasing in weight over the time? Because that's what we tend to see. And we could talk a little bit about our food environment.
On a different podcast, probably.
Maybe so, yeah. Uh, but this is for obese people, I would say I really wish they were covered because they are effective and they are safe. I'm a cautious person when it comes to medication, and I'm all about I've had people say no, I just, I can never stop being nauseous even on the little tiniest dose, and even taking it every other week instead of every week. And I'm like, okay, you're just super sensitive to it, and that's, we won't keep you on this I'm not going to force you to take anything, but I'm like, okay, this is not a medicine you tolerate. But a lot of times you can get somebody on the medicine if you start really low and increase very slowly, over months. So,
And doctors have told me that it's just a matter of titrating the dose, the nausea and the other GI complaints, that if you just taper off, then still the satiety is taken care of, but the GI complaints are lessened. It's amazing because I have known a number of people on those. And of course, I'm thinking about it because we've been talking about it for months. And in my family, in my extended family, many people have been on them. I've never heard a story of failure. It's amazing. But you taking care of lots of patients. Have you had patients that have failed on a GLP-1?
well, you have to think, so basically my patient population who are taking them are diabetics. So in terms of the success of having their hemoglobin A1C, the marker of their diabetes, being better,
Yes.
they don't fail. I agree with you. My patients, I have not seen that fail. I have seen patients not lose weight. Now, a lot of times their trajectory was gaining, 5, 10 pounds every year, their whole life, every year, their whole life. So plateauing is success
Yeah.
in
Yeah.
that sense.
Yeah. No delta. Yeah.
Right. So I've, I wish that we could prescribe them for non-diabetics in my patient population, but I think there is definitely medical reason to do so.
Yeah. So I think
Yeah.
what you're getting into a little bit, and I'm very interested in your take on this because clearly these are not cheap drugs, and
Right.
that's why you're bringing up Medicaid, Medicare, because of some sort of coverage for your patient base. And so maybe one of the ethical arguments that's just upon us and will continue to, become bigger and bigger is, obese patients who don't have insurance and are going to have health problems, these markers for disease that obesity represents. So are there programs? Have you been able to link people up just for obesity with programs from some of these companies that are making, we already know, billions and billions of dollars?
Right.
Have you been able to link them up with a program so that they can afford it?
Only if they have insurance. So there's bad insurance out there in that it doesn't cover much. But if you have any kind of commercial insurance, you can sign up with the company. I think Mounjaro is $25 a month, is what you end up paying. But you have to, right, I've looked at those applications, and you have to say you absolutely do not have any public insurance, meaning Medicare and Medicaid. That is and I'm not going to ever encourage my patient to lie
Yeah.
on those,
Right.
right? And so there are some times that brand name drugs have programs, but they don't specifically ask, a lot of time, if about public insurance, but for this, they are, so I don't know why. If somebody, if a listener could, knows why they're not allowing Medicare, Medicaid patients to access, because these programs are like, you pay for Mounjaro, it's 25, as I said, but for Ozempic, I think it's $4.99 a month. They're paying $499 for basically, self-pay, but you either self-pay or they have insurance. So
Yeah.
yeah.
Well, the review that I read in JAMA from a couple of years ago talked about basically traditional discipline, exercise, decrease intake, and what the percentage of body on average of weight loss is versus now GLP-1s versus bariatric surgery with or without GLP-1s. And certainly it's a gradation. It's moving up in percentage with some of the more recent GLP-1s, one of which I think is from Eli Lilly that's pending approval with somewhere between 18 and 21% weight loss within the space of, I think, 18 months. So pretty dramatic. So
Right. I want to talk about, oh, sorry.
I was just going to say now, that's success. What happens after that success? What's the maintenance? What does maintenance look like for these patients? Because the
Right.
recidivism must be high. It has to be high.
Yeah. So if you just stop a medicine, stop one of these GLP-1 agonists, receptor agonists, that's what the whole name is. But if you just stop them suddenly, then the studies show that 70 to 90% weight regain. Now, 90% is not 100%. So there was like, we're talking, it's definitely weight regain, but there's something happened in the body that was at a lower weight for a time. And there, I know this is controversial in the obesity literature, but about the set point for that if you are at a certain weight, your body thinks that's the weight it's got to be. So if you starve yourself like a diet, and you just stop eating, then your body is going to be, oh, let's slow this lady's metabolism way down because she is starving and we need to have her weight go back to where it was, the set point, right? And so there is some of that happens, but now some recent studies, if somebody wants to get off them, the recommendation is to wean slowly, to slowly do it, not just like go from a high dose to zero, but to go slowly down. And then there's a lot of talk in this world of this literature about just the very lowest dose and every other week. So you're just giving a little teeny bit of it, every once in a while you're getting it, and it just cuts and it just allows somebody to continue to make healthy food choices. And when you were talking about, I was thinking that helpful would be to talk about our food environment just a little bit right here.
Go for it.
Because why is obesity exploding in America? If you look at the percentage of people obese, and yes, people are more sedentary, they're looking at screens and not running around. But we also have so much processed food available to us at every, corner. And fast food, which is very processed. And by processed, I mean, it's basically been exploded. The nutrient, you do have protein there, you have carbs, but they've sort of exploded it so that they can make the nuggets all look identical, and because they re-put them back together again. First they explode them, then they put them back together again. And so that means that even though, yes, it was a chicken at one point, it is now easily distributed in your body, and absorbed as very small molecules. It doesn't take much to get it to sort of gives you a burst of insulin, to get rid of, to manage that. Yeah, so I think, people talk about a toxic food environment. I just call it a difficult food environment because people come in, how do we celebrate? We celebrate with food, we celebrate with sugar, fat, and I don't have a problem with a lot of fat, but there are, if you add simple carbohydrates to fat, then and salt, they call that the sweet spot, I think, in food lingo, where they're trying to get you to buy more of these, junk food chips or whatever. And so they're just making it taste so that we're talking about addiction. We're talking about food, people who sell food who are trying to get us addicted to that brand, that type of food. Whereas healthy, I much prefer that my patients eat real food, food that grows in the ground or that was an animal and, that is not been processed by companies and has an ingredients label. I'd rather they ate actual food.
Right. So I'm guessing then where that you take some patients during this fast food holiday that these GLP-1s potentially would take them through, that you do counseling, give them lots of education to help them so that in 2, 3, 4 years, whatever, when they've had the weight loss that you want them to have and that they want, that now they've had a chance to recalibrate their eating habits. Is that generally your habit with your patients?
Yeah, that's the hope. You want to get them physiologically and metabolically, you want to get people below the obesity threshold, which is a BMI of 30. But even overweight, which is a BMI of 25 to 30, is a higher risk environment. So, but these might be lifelong medications. Yeah. It might be that somebody, in order to dampen down that food noise, needs to take them forever. Now, with a caveat in that I was going to say this when you asked about, are they always successful with losing weight? And I have patients, if they don't lose weight, their diabetes may get better, but if they're not losing weight, we start talking even more about why are they eating. And a lot of times people are eating from stress reasons, and, their dog died and they have a stressful job or whatever. And if you're eating for stress reasons, they don't help that, right? Mm-hmm. If you're feeding some kind of, I feel better when I eat because, it kind of is filling up an empty spot in my heart. Well, GLP-1s don't help with that. They help with hunger kind of eating. So I do try to talk to people before I ever, we have quite a discussion before I put somebody on a GLP-1.
I'm sure, Amy, that you've talked to lots of your peers, and you probably have a daughter that you have conversations with.
That's right.
And because she's younger and maybe has a different patient mix, I don't know. But compare and contrast your approach to the use of GLP-1s with maybe others that you're aware of that you've had discussions with. And I've had several with family docs about this, but not that many yet. So I'm just curious for our listeners to hear, how do different primary care doctors approach the use of these drugs?
Yeah. So that's helpful because I've already decided, even though I am sort of an enthusiast for these drugs because I think they're really safe, I think amongst my peers, like people here in Louisiana, who I go to church with or whatever, and we talk about it, a lot of people are already thin, okay? They're already normal weight, but they're like at the high end of normal weight, and they want to be at the low end of normal weight. There is no advantage to going from the high end of normal weight to the low end of normal weight. And so I discourage people from doing it, but, our culture is rewards
it values thinness.
Yeah,
yes.
Values thinness. Yeah. So that is something that I think we need to watch out for, because that's sort of more in the vanity, camp. And so we have to be careful with that. This needs to be a health tool, I think.
So 10 to 15 years, that's the number that I have heard you say. I've read in the literature that we've been using these for about 10 to 15 years, especially for diabetics. And that maybe one of the downsides is I went to AI. What are the downsides of using GLP-1s? One of those is, we really don't know, long-term outcomes from using these. So are there any things that you have thought about or seen in the literature which people are saying, maybe we haven't had enough time to see this problem yet demonstrate itself?
Yeah, you asked me that before, so that is one thing I've really looked for. I've read multiple things, and we don't see it yet, and that's the thing. You can't see a long-term side effect that only shows up long-term
Yeah.
if you haven't been using them that long, because the ones that we had, in terms of the class, were not nearly as effective as these. So my only thought of that is that if you ask a receptor, and this is just me being, I have not read this. This is just me thinking about your question. But if you're asking a receptor to, and you're putting a molecule that attaches to it more strongly than the one that God originally made, the GLP-1 lives very briefly in the body, but we're giving these GLP-1s and it's a much stronger attachment to the receptor. So is there a long-term consequence to that? I don't know.
So clearly what's happening in some populations, I don't know that it's in yours, but that people aren't eating at all and not getting enough protein. So I've been reading about muscle wasting.
Right.
So, and I just had a staff, since my chapel that I shared yesterday, one of the staff came and said, "Oh, Dr. Chupp, I would love to lose 25 or 30 pounds, but my doctor says, no way, I have osteoporosis and I've had this problem, and she won't let me take a GLP-1. So how would you respond to that?
I don't know. I'd have to know her story, Yeah. Is she overweight, or you think?
Not terribly, but yeah, like 25 pounds. Yes.
Yeah. So when you talk about protein, I really want to emphasize the need for protein, because actually when I have a patient on a GLP-1, I talk about protein every visit. Mm-hmm. I talk about protein and I talk about strength training, because if you lost weight because you just stopped eating, or, really cut your calories, you would lose probably 30-ish% of the weight loss you lost would be if you just ate the same diet. You would lose muscle mass. That's not good. We don't want to lose any of our muscle mass. We want to enter old age with vigorous muscles. And so we all know frail older people with sarcopenia, which means their muscles have wasted away. And so we do not want that to happen to our patients. So what I say to people is, if you don't have much of an appetite and you don't feel like eating much, you need to eat something, but it's protein. You need to have healthy protein, meaning actual meat, beans, avocados. You've got to have, food that is rich in protein. These yogurts nowadays, they've got massive amount of protein in them. It's like, great, just you need the first thing you eat, if you're only going to eat a little bit, it needs to be protein. And then bind that together with strength training, weights, doing weight exercising, is to keep those muscles so they don't waste away.
One of the questions I wanted to ask you, and you've described this just a little bit, but then, what monitoring? I mean, a lot of therapies require all kinds of lab tests, but other than weight, which is an obvious one, what other monitoring are you doing? Anthropomorphic measurements, or what do you do in your practice?
I think some people are, but I'm not. I'm just looking at their A1C go down, down, down. I just love it, But yeah, they don't seem to affect electrolytes or whatever. I mean, I'm monitoring those, but I'm monitoring protein intake, and I'm having, when I see them 3 times a year, whatever, I'm asking them about protein to make sure that they're eating enough, because that is where they're going to lose their muscle, and I don't want that to happen.
As we start wrapping this up, I do want to ask you, would you respond to colleagues? I was with 5 up-and-coming second-year medical students just a few evenings ago, and who've heard you talk about non-opioid pain management, and appreciated your lecture, because that's another area where you like to share with audiences. And when I talked about this whole arena of GLP-1 management, one of the students, actually the one of the 5 that I know the best, just said, Dr. Chupp, this just doesn't seem right. It doesn't seem right that something would be so easy and would not require any discipline and it just works. And aren't we about teaching our patients and training our patients how to show discipline and to do more exercise? And it just doesn't seem like this is rewarding good things in our patients. So how would you respond to that end of first-year medical student who's getting ready to take his first-year finals?
Well, I suspect he's thin.
He's very thin and very muscular.
Yeah, there we go. And he's young. So I used to be 70 pounds heavier, and I started eating low carbohydrate, about 10 years ago, and I lost the weight. So that's the way I eat because it worked for me, and I actually really like the diet. So even though I am normal weight right now, right, sort of in the middle of normal, I'm very sensitive and sympathetic and empathetic and all those words with my obese patients because that's me. If I was not eating the way I'm eating, I would be obese. I know it. And probably a lot of more health problems than I have right now, which are pretty small. So I think there are people who are thin who are like, oh gosh, just don't eat. I mean, it's easy for me, so it must be easy for you too, because it's just easy to not eat. But I talked about that food noise. It is really hard to constantly fight a voice in your head that's saying, gosh, you are hungry right now. You are really hungry. No, I'm not hungry because I just ate an hour and a half ago and it was a good meal. No, you're hungry. And look, I think there's some cookies. You can go get them. This is what the things that are going on in people's heads all the time. And to have that, just to be able to dampen that down, that's a mercy, I think. Mm-hmm. Yeah. And we also help people who want to stop smoking with medications, right? Because we know it's addictive. I think there's a lot of foods that are addictive. My personal belief is that sugar is addictive. Mm-hmm. It certainly was for me.
It's a dopamine hit.
And yeah, and so we want to help people get over addictions, and there are alcoholics who take medication to help them get off alcohol. And so, and before I pass, they've already done, the big study came out a few months ago about alcohol with GLP-1s, and they help alcoholics get off alcohol.
Wow.
There's several big studies ongoing about tobacco. It's not out yet, so I can't say it, but it makes sense. There are also studies on gambling, because that's another thing that people do compulsively, and they seem to help. It seems to help with that. This is all anecdotal at this point because the studies aren't done, but just that craving, unless somebody has lived with that and just, I don't know that they're going to understand what their patients are going through.
Amy, you've mentioned several things. A couple of things I didn't know were indications, but are there other indications people are talking about? I've heard some talk about even polycystic ovary syndrome as something that seems not related to me. How does that work?
Right. So that is actually a metabolic disease, PCOS. And so it's not too surprising. I think the studies are ongoing. I don't think they've been shown yet. What has come out is decreasing cardiovascular event risk. And that is in diabetics, no surprise, yay, but it's non-diabetics too. It's 20%. And that was, I think, SPRINT trial. There's a SELECT trial and there's a SPRINT trial. And it's one of those is about a 20% drop in cardiovascular risk of event risk. So heart attack, stroke, PE because of blood clots, and sudden death, and that in people who are using GLP-1s with or without diabetes.
And that was a pretty big trial. Has it been reproduced as well?
Yes. Well, I don't think so. I mean, I don't think so. I mean, now probably there's another study, a confirmatory, but people are pretty much going with it. And I knew about that only because about probably 6, 8 months ago, I started having my patients, who also see the cardiologist, our cardiologist, who coming with a GLP-1 prescription that they were able to get, but they don't have diabetes. And so there are cardiovascular indications that it's getting covered, not by me as a family doc, but by a cardiologist. Also, kidney failure. It decreases the progression of kidney disease to chronic kidney disease to failure. It decreases the rate of that. Yeah.
I have to believe, Amy, that recruitment for future trials is going to be a piece of cake because the medication is going to be paid for, and yes, it's going to be placebo, double-blind controlled, but 50% chance of being on these drugs. And placebo in this situation with all that head noise, I've got to believe there's a significant placebo effect.
Correct. Yeah. Any medication is about a 30%. Placebos are so fascinating. That's another subject we have to talk about someday. I love the idea of placebos because it's giving somebody a 30% chance that this medication will work if you give it to them saying, I think this will work. Even if you tell people it's a placebo, it still works. It still works. Yeah.
Fascinating.
Yeah.
Well, I do want to appreciate and let our listening audience know that though Amy knows the Word of God very, very well, together with her husband, Don, I've thought about asking you some biblical questions, even some theological, but we have a special guest next week coming onto the program, Dr. Kimberly Cook from Dallas Theological Seminary. And I've saved most of those theological anthropology questions for Dr. Cook, and we will get into enhancement and human flourishing topics as well. But I wanted to have one of America's doctors who's been on numerous podcast platforms, Dr. Amy Givler, to give us the basics clinically about the GLP-1s. I think it says a great deal that you, like a lot of our CMDA members who are primary care doctors, are cautious, conservative, and not necessarily cutting edge. So it's going to say a lot to you in the listening audience that Dr. Amy Givler is very positive about these medications. You've heard her talk about them today. So Amy, I want to thank you for joining us today on Faith and Healthcare. And I'm going to figure out another topic that we can have you back for one of these fine days on one of the things that you like to talk about. So thank you. Our love from CMDA to you and your husband, Don.
And I can't wait for next week. Looking forward to Dr. Cook.
Thank you. God bless you, Amy.
Thanks. Bye-bye.
Bye. Friends, GLP-1s are not going away. Whether you came to this conversation as a clinician, a patient, or simply someone trying to make sense of what you keep hearing about these medications on TV through many advertisements, I hope this episode gave you a clearer picture of what the science says, what responsible prescribing looks like, and what we still just don't know. At the heart of this conversation is something that Dr. Givler models quite well, bringing wisdom, humility, and genuine care for patients. It's a topic that culture has been quick to sensationalize. That is what faithful healthcare looks like. So I want to thank you, Dr. Amy Givler. If this conversation encouraged or equipped you today, please consider sharing it with a fellow clinician or a friend who needs to hear it, and subscribe so that you don't miss future episodes of Faith in Healthcare. Next week, Dr. Kimberly Cook from Dallas Theological Seminary joins us to continue the conversation on GLP-1s, this time from the perspective of theological anthropology and biblically sound ethics, exploring human flourishing, creaturely limitation, and what it looks like to pursue transformation while remaining faithful to who God made us to be. You won't want to miss it. Thank you for listening to Faith in Healthcare, where our promise to you as a listener, or better yet, a subscriber to this podcast, whether a healthcare professional or a patient who loves Jesus Christ, is this: we will do everything that we can to keep your faith and healthcare connected. We'll see you next time, Lord willing.